the room. So a lot of the newly trained EMDR therapists are really curious about the practical application. How do you do phase one with a kid and gather that history? And how do you do phase two and prepare them? Because a lot of our work is based on the adaptive information processing model, and this person is has like 5 years of life. I'm wearing shoes that are older than the person that's in front of me. How do I build up?
In this video, I'm talking with Jackie Flynn. Jackie is a licensed mental health counselor, qualified supervisor in the state of Florida, registered play therapist, and a certified EMDR therapist at her private practice in Central Florida. Jackie is also the founder of EMDR and Play Therapy Integration Support, the host of the EMDR with Kids podcast, and EMDR with Kids community. Um, in addition, she is the host of the annual Innovative Child Therapy Symposium. She is an approved provider for the Association for Play Therapy and EMDRIA, as well as an EMDRIA approved consultant. Jackie will talk about how to integrate EMDR and play therapy, how co-regulation is different when working with kids, and at the end of the video, she will do a little demo on how to apply bilateral stimulation with kids when doing EMDR with children. Here is the interview. Jackie Flynn, welcome to the Art and Science of EMDR, and thanks so much for joining me today.
Oh, thank you for having me. I'm excited to be here.
Thank you. So, Jackie, I invited you to the show to talk about how to do EMDR with children. And I want to start by asking you, when EMDR therapists finish their basic training, they don't really know how to work with children when it comes to EMDR. Even when they're experienced EMDR, when experienced therapists, how to apply EMDR can be a little challenging. So I wanted to ask you, what are the most common challenges that you see when it comes to applying EMDR to working with children?
Oh, I have to say I agree with you. EMDR is complex, and there's a lot of things to know, a lot of things to remember. And over time, you get familiar with it, just as like learning how to drive a car. So it doesn't always remain that complex. But there's a lot to know, especially with the basic protocol. So the basic training that EMDRIA provides, which is fantastic, it really hones in on how to use it with adults. And we need to know that solidly. We need to be able to know the 8 phases and be able to really know the goals of each phase and what's the intention. And then when we feel really good and solid with that, then pursue advanced training, advanced consultation to really kind of gain the extra skills that it takes to really use it with kids with fidelity. I know sometimes people think, well, it's probably easier to do it with kids than adults because they're so young and they're probably less judgy. But it is definitely, it takes some extra skill set in terms of integrating play therapy techniques, working with them in a developmentally appropriate way. When we're working with a child, often we're working with the parent or the caregiver. So really just knowing that through the basic training, good and solid is what we need. But you come out of basic training thinking, okay, most of my clients are children. What do I do? I know what I did. I looked to Anna Gomez. She's like one of the pioneers at Carolyn Settle, Robbie Adler Tapia, and Carolyn Settle, and definitely Deb Wesselman, all of their work. I gobbled it up like I was just starving for that information. And when you do that, it's like you get this knowledge base that then you can pull from wherever you need it. So I definitely recommend learning how to do it with adults nice and solidly, and then gathering information, training, consultation, books, to really support your child therapy work.
Yes, I want to specifically talk about differences that you see, or what when EMDR therapists come out of their basic training, what are they struggling with? So how, because we know that there's not a lot of time spent in basic EMDR training explaining how to work with children. There's a very short section, and then you move on to the next. So what are the most common challenges that you see for EMDR therapists who are newly trained to apply EMDR when they work with children?
Yeah, the practical application knowledge of it. Okay, so I understand what it is and how it works, but how do I actually do it? What am I going to do in this room with a 5-year-old that's playing at the dollhouse or throwing sand up in the air, or that's doing sand tray therapy, or that is working with expressive arts? How do I use it with someone that isn't sitting still on the couch just waiting for my directives to follow my fingers and just let whatever comes up come up? With kids, you may be following them around the room. So a lot of the newly trained EMDR therapists are really curious about the practical application. How do you do phase one with a kid and gather that history? And how do you do phase two and prepare them? Because a lot of our work is based on the adaptive information processing model, and this person is has like 5 years of life. I'm wearing shoes that are older than the person that's in front of me. How do I build up their adaptive information um, to really be able to support that? And then the most common question, how do I do the bilateral stimulation with a child? They may not tolerate that, whether it's holding on to the pulsars, the vibrations, if they have sensory uh, processing issues, or getting them to just kind of follow your finger. A lot of the deepest trauma work with kids involves that non-directive play, because what we know about trauma is people have this felt sense of danger inside of them. So as therapists, we need to create the safest environment as possible. And the child-centered non-directive approach is absolutely one of the most robust ways to make this the safe, I'm with you right now. And how do you do this in this very kind of structured 8 phase model? So that's where, I work with clinicians that are already trained in the basic, but then we take that EMDR definition from EMDRIA and really kind of pluck out what are the goals of each phase, and then how can we meet the criteria in each phase, in each for each goal, in developmentally appropriate ways. So that's what clinicians are really curious about. Like, what do I actually do?
Yeah, and we will do. You will show at the end of the this video. You will show a demo of how to do BLS with children. And I know you have very creative ways, so I look forward to seeing that. But before that, I wanted to ask you something that I personally am very interested in, and that's co-regulation, and that's something that you talked about in the past, and you specifically how to apply the polyvagal theory when working with children and how to coagulate um, children. So I'm in my work, I'm more interested in the adult perspective. But now I want to ask you, how does it work? Polyvagal theory, coagulation with children. What are the similar things? What are the different things between coagulation with adults and children?
Mhm. I would say something that we as adults have in common with children is we are all human. And as humans, we are on this quest for safety. I love Dr. Porges's book on the polyvagal theory, and I've learned so much from Deb Dana, and just being able to create a safe environment in the play therapy space. But with children versus adults, like we know how incredible it is, but what does that actually look like practical application wise? What do we do as child therapists to create this safe environment, especially in our EMDR sessions, that sometimes we are working with clients that have experienced some deep down felt sense of trauma that could have even occurred in utero or preverbal trauma. So it's something that we need to focus on the cues of safety and really recognize that some things can be cues of danger, not intentionally, of course, from us, and think through our approach very intentionally. And, when we think about the polyvagal theory, there's three organizing principles. There's that neuroception, just kind of, I need to feel safe inside my body. And in these sessions, I'm in my body, the client's in their body, and together we're together. So that neuroception feels safe in my body. They need to feel safe in their body, but we also need to feel safe as in connection with each other, right? And then there's the co-regulation, just that I am with you. So suppose in this, I've made changes over the years. I used to book my child therapy sessions back to back. I think, okay, now I can see 6 clients a day. If I carved out time in between, I'd only be able to see 5, and I want to see 6. Well, that is one of my best changes I think I made, is to carve out time in between the sessions so that I could regulate myself. I can take a walk and do some of those regulatory breath work and be able to kind of pull the room back together and reset before the next client. Because with children, really with anybody, I don't think it varies that much, besides the fact that our children are, their brains aren't fully developed until their mid 20s. So a lot of times they will experience dysregulation more frequently than we do as adults. But with children, they feel, we share nervous systems. So if I'm dysregulated, I come in all worried, like, oh my goodness, I'm going to be late and I got this and that. I'm not with that client. And when someone's not with you,
Right.
and that doesn't feel safe. So
Right.
that's how I would say that extra, just send as many cues of safety. So, and predictability. So with child therapy, we make sure that the toys, which are also tools, they are in relatively the same place as they were their previous session as much as possible. We start on time. We're not running late. We make sure to make connection with them. We can, nose to toes is what it's described to in the child parent relationship therapy. Like, I'm looking at you, I'm turned towards you. You matter. That's one of our positive EMDR cognitions. The noise level. I'm a safe and sound protocol provider, and I noticed that. Like, I love using that protocol, the SSP, with my clients. But I noticed that if my neighbor in the office next to us is noisy, it's a different vibe in the room. And it may be a cue of danger, especially someone that has, maybe they're, when we think of, the three in the polyvagal theory, there's a hierarchy: the ventral vagal, sympathetic, and dorsal vagal. They may already come in activated, and that noise may just increase that activation. So all those things, having my phone turned off, even if I don't pay attention to it, if it rings, may be a cue of danger. It may be like startling. Making sure that you speak in a way that conveys, like, I'm interested in you, I'm with you. uh, just really paying attention to those cues of safety, and checking in on yourself. If you are in your sympathetic state and you're activated, then you're not going to be able to be that external regulator as much for the kid. And I think a lot of times, and I used to be a school counselor, and I would see in some of the IEP plans, one of the goals is to get this child to self regulate. We come into this world needing connection with others. We're wired for connection. And if we don't get that, it could be that cognition of, I'm going to die, right? So if I'm working with a child that experienced neglect, even one of the common practices is letting a baby cry it out at night, so that the baby would actually fall asleep and then everybody get rest, is the concept. that in itself can be a trauma for the child because they are expressing this hunger, this need for connection, and no one comes. So they recognize, like, I can't trust that someone's going to be there with me. So when I'm working with a child, if I'm not in that space to where I can connect and be with them, I can't expect them to regulate themselves just out of the blue, especially while their brain's still developing. So the co-regulation, especially with children, is the we that Dr. Siegel talks about. That I have mine, the child has theirs, and together we have something. So that's safe inside, safe outside in my environment, but safe in our connection with each other.
Yeah, thank you. That was very helpful, and I really like what you said about, yeah, you see 5 clients instead of 6, but you're, for these 5, you're a lot more present, you're more regulated, your nervous system, you're coming with a nervous system that is ready to do this co-regulation, right? If you're seeing one client after another, a lot of times you don't have time to, and sometimes some um some sessions are harder than others and more challenging and more, some kids are more dysregulated and you need to regulate yourself. So I think it's, thank you for mentioning that. I think that's really important.
Oh, yes. I would say when you say that, that's so true. Sometimes they will hit you with a toy or they'll throw sand in your face. And then you're like, I have sand in my face. I can't open up this eye. I mean, it can get intense where you feel dysregulated. So I do need to give a big shout out to Lisa Dion's book, or Lisa Dion herself, but her book, Aggression in Play Therapy, is by far one of the turning points that in my work to where it really, like in the moment somebody throws sand in your face, you're very dysregulated. You can regulate yourself in that child's presence. And when the child is experiencing that regulation with you, that's truly the co regulation. So she is the creator of synergetic play therapy. And I would say it is by far one of the most powerful things that I've learned throughout my work. But through the co regulation, you can't really talk about that without our, as parent or as therapists that work with children, we work a lot with parents and families. So the you ask, say, what happens after the child acts out? Well, they get a spanking, or we had to restrain them, or they get time out. All of that is very dysregulatory to the nervous system. And parents, and I'd fall back on the Maya Angelou quote, we're, when we know better, we do better. Parents are doing the best they can. Parenting's hard. I'm a parent myself of teenagers. It can be so difficult. Sharing this information with parents, saying, okay, instead of this, let's try this. So the parent's nervous system is in that ventral vagal state, or at least close to it, and then the child can co-regulate with the parent. That's where we have the most impact, is really being able to help change the environment that the child's in, not just the work with the child in our office, but being able to share some of these things with parents that are just a lot of times hungry for information, that may
Yeah,
experience trauma themselves.
absolutely. And then the parent can become dysregulated as a result of the child's dysregulation, and then they kind of feed into each other. um I wanted to ask you, Jackie, if you would be willing to do a little demo of BLS. I know that you have a lot of creative ways to do BLS, and I know therapists are really interested in that, especially when working with kids. It's not enough to turn a light bar on or the buzzers on and say, notice that, but there's more creative ways. So if you would be willing to do a little demo of your creative playlist, that would be great.
Absolutely. In fact, you turn on the light bar and they're anything but sitting back watching it. They're like trying to push the buttons and stuff. And then they may be like, "Grr," and then you're totally out of activation. You're more of in curiosity mode. So before we talk about the actual what do you do, we need to look at what is the actual intention, the function of it. It's to activate the right, left, right, left alternately. So what we can do that, we do it every day in our natural state. We walk. That's why a lot of times people report like a sense of release, a regulation after they've taken a jog. One of the reasons we move our arms back and forth. We may be playing in sand or Play-Doh. So knowing that anything in the play can actually be bilateral stimulation that's moving the right and the left side of the body. So a lot of times I'll, s- I'll say, okay, let's stomp that out and we'll stomp together. And that's how co-regulation works is we're actually doing the BLS together. Rarely do I say, just stomp that out and I'm just standing there because I'm not matching the affect of the child. Say, okay, let's do the gorilla tap. Let's tap that out. And know that if they're making sounds, then they can vibrate the vagus nerve. Then that actually helps with the kind of moving back to that regulated state. Also, taking a stuffed animal and just kind of tapping like that, something that's a little lower key. We definitely do, the butterfly tap. Also, one of the big things that I do a lot of times, so children that I work with, maybe adoptees that have experienced attachment ruptures, that I may have the parent in the session, and in a real loving way, I'll have them just tap on their shoulders, and I'm just guiding with my hands. I'm pacing, and then I'll make the stop signal. That way, they have the connection with their parents. I may use a puppet to do the eye movements, like, and
Mm.
this is one that's actually semi, like, kind of like
Oh,
a
nice, double-sided.
yes. And also with children, I mean, with adults, we can easily kind of go so many passes and they're still engaged. With kids, sometimes it's only a little bit before they're off to something else. So you have to move around the room, and their play is actually their communication, their expression. One of the common misconceptions about play therapy is that it's a way to get them to talk. Now, certainly we talk in session many times, not always, but it's the actual therapy is the medium for the play is the medium for the therapy. So another way we may do the BLS is I will have like a car, and okay, when I say then you're gonna roll that through the sand. So and then think about what's in your mind right now and in your body. Okay. And then we have like little races in the sand. We may do like a pinwheel, like sometimes children can't tolerate BLS, especially if they have autism spectrum disorder or sensory processing issues. Any kind of tapping or buzzers, or even asking them if we're doing a sword fight, and I'm asking them, okay, hold that thought and that image in your mind, and let's do a sword fight. Now your turn. Sometimes they just it takes them too much in that directive mode. So one of the backups that we can do is get a dual speaker, Bluetooth speaker, put EMDR music on there. Now, is that the optimal? Not really, because we could stop and paste it, but it takes us out of that connection with the client. But it has like the whoosh, 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 and you can still follow all of the procedural steps of EMDR. Like in phase 3, we get the image, we look at the emotions, the body sensations, we elicit the cognitions, and we get the measurements, the SUD and the VOC. You can still all do that through the play. And if we're using the speakers, it's just whoosh, whoosh, and you do see change. Now, is that the preferred approach? No, it's challenging, but I'm here to tell you it can work. I've worked with kids literally in 1 or 2 sessions, and they have had such significant change. One of my things that I specialize in is helping kids that are experiencing night terrors. We can target the night terrors. We target so many different things. It is incredible. You see relationships start to get healthier. Their feeling of self worth. They start to make different choices. They move back into, like, if they're shut down and they're in that dorsal kind of numb phase, they move back into activation, and you start to see some of that activation and that processing and the energy come out in the play, maybe a little bit of aggression, and then they're able to get back to their ventral vagal state. It's fascinating.
Yeah. That and that's very helpful, all this information, especially for our viewers who could actually watch you demonstrate all these, applications of BLS with children. So Jackie, before we say goodbye, I want to ask you one more question, and that's, how do EMDR therapists get better? So beginner EMDR therapists get out of basic EMDR training. How do we get better?
How do you get better? By I'm a big believer in the 8 phases. Really study those 8 phases. So what I did in the beginning, was I had a hard time, just to be completely honest, it felt like basic training was so much, I couldn't digest it all. So I had a hard time even knowing where I was at. I was like, "Okay, I think this is a good time to do the BLS." Not really working with intentionality in the beginning days. So I got the EMDRIA definition, which if you go to Google, you can just put an EMDRIA definition PDF, and very clearly, a 3-page document very clearly defines what is in each phase. Also, I have a video on YouTube too that you can, see the goals in each phase. I put that by my desk. And as I'm writing my progress notes, I'm looking, okay, today we did phase 2. And in phase 2, I supported the client with affect regulation management. Okay. Oh, and we created a peaceful place. And I started to really refer to that EMDRIA definition for the verbiage. And then I realized I know this definition. I know what happens in each phase. And then I felt solid on that. And then I've been reading Anna Gomez, Carolyn Settle, Deb Wesselman, Robbie Adler Tapia, just really seeking out all these people that were so influential. But then when the breakthrough came, I was to get consultation and get consultation from someone that really knows how to work with kids. And I recommend you don't just get one consultant, you search around, you really customize it. You look for, you can even look for somebody, suppose you really are inspired by somebody, but they don't work with kids. Get consultation from that person and apply it to your kid work. Suppose you don't have any play therapy knowledge, but you work with kids and you've had a lot of EMDR training. Go get consultation from somebody that just does play therapy and plug that into the 8 phases and mesh it all together. Just search out information in those advanced trainings and opportunities, just like you're hungry for nutrients. And then you get to where it's like you have this very customized to whatever theoretical orientation you're drawn to. You have this, what feels right in your heart, and that's when you put your best foot forward. So advanced trainings, consultation, supervision, books, just gobble it up.
Yeah. Jackie Flynn, thank you so much for your time and for this useful information.
Oh, thank you for inviting me.